Everyone, it's 1 minute after noon, so we'll get this thing kicked off. Welcome to you all. I'm Susie Keller. I'm the CEO of the Idaho Medical Association, and we are very pleased to partner with our colleagues at the Idaho Department of Insurance to talk about their implementation of the No Surprises Act and how they intend to implement the act. As it stands at this time, there is some litigation ongoing, but as it stands at this time, to make sure that everyone understands how this will be implemented in our state. So again, thanks to our colleagues at the DOI. And with that, I will hand it over to Shannon Hall.
Thanks so much, Susie. Really appreciate it. And thank you everyone for being here. We're really excited about this opportunity to partner with the Medical Association and its members. My name is Shannon Hole. I'm the Market Oversight Bureau Chief here at the Department of Insurance. And we have an awesome team of staff who are going to walk you through the No Surprises Act and what we think providers need to know about making sure they're in compliance with this act. Susie mentioned, and we're going to mention it a few times today, this is an evolving situation. This is an evolving, it's not evolving law, but the regulation and guidance is evolving. So CMS is continuing to provide information. And so everything we're saying today is accurate as of today. And it's our goal that we'll continue to provide updates and information to all of you as things change. I also just wanted to mention, please feel free to share feedback with us after today. You can contact us. Amy and her team will walk through some options for how to get in touch with us. But we do feel that this is a partnership. We've been tasked with this enforcement, but we see it as a partnership between the Department of Insurance, providers, carriers, public. And really our goal is to make sure that Idahoans understand their rights and protections under this new law and how they can get help if they have questions, and also for all of you to get help if you have questions. So thank you for being here today, and I'm going to hand it over to Amy Lambrecht, our Consumer Affairs Supervisor.
Thank you, Shannon. And again, I too want to thank the IMA for sponsoring this and inviting us to participate in the presentation today. As we say, it's the No Surprises Act, and it's very basic information for providers is our intent. With me today is Consumer Affairs Officer William Kuhn, and he's going to help present. Also on the line, we have another staff member, Audra Gerard, who's a Consumer Affairs Officer. I just want to mention her because she will be one of the staff members responsible for helping the public with the No Surprises Act and helping with implementing the regulations. So I just want to give you a little bit of our outline here. First, I want to talk a little bit about the Department of Insurance and Consumer Affairs. And I always love the opportunity to talk about my section, Consumer Affairs in the department, and how we can help the public and what our role is. Then we'll get into the information that I think most of you are here for, is talking about the No Surprises Act. And again, I'm stressing basics for healthcare providers and facilities. So we're focusing on basic information that you need to know as a healthcare provider and a facility, health facility. We'll touch on out-of-network balance billing, NSA patient disclosures, continuation of care, provider directories, and good faith estimates for uninsured and self-pay consumers. But first, I want to talk a little bit about the Department of Insurance. We are an administrative agency that our primary role is to enforce the Idaho Insurance Code, and we regulate insurance in Idaho. I always love to talk about our mission statement, no matter who I'm presenting to, because our role is to serve and protect Idahoans by equitably, effectively, and efficiently administering the Idaho Insurance Code and the International Fire Code. The reason why I say that is a lot of times my section, especially, we're called Consumer Affairs, and people think that we're just here to advocate for consumers, and we absolutely are. But we also want to get the word out that we're here to help the public at large if they have any questions or problems regarding insurance. So we help consumers. We help, could be a business, insurance agents, attorneys, anybody that has a problem or question about insurance, we're here to help them. So with the Federal No Surprises Act, I'm going to talk about that a little bit. It becomes effective January 1st of this year. And the intent is to provide new protections for consumers and new requirements for healthcare for health insurance companies, medical providers, medical facilities, and air ambulance services in certain situations. And we're going to talk about those in certain situations a little bit later, but really the intent is that it's to protect consumers, and it affects insurance companies as well as you as a provider. And again, even though this is federal regulation, we're kind of stressing, our role typically at the department is to enforce Idaho laws, the Idaho Insurance Code. But now we've been tasked, the Centers for Medicare and Medicaid Services, that as the Department of Insurance, we are tasked to implement the enforcement of the NSA for Idaho. The guidelines, the rules, and the requirements of the NSA are being provided by CMS. And you've kind of heard this thing before. What we really need you to know is that the rulemaking and guidance regarding implementation of the NSA is ongoing. So part of what we're doing here today is to provide you basic information. And then we'll provide you information of where you can go to look for additional information as it is implemented and as new information becomes available. I'm going to talk briefly, though, about my section. Again, we are here. Our primary role for consumer affairs is we answer calls and inquiries from the public about insurance issues or laws. We analyze, we actually investigate consumer complaints, maybe is the more accurate. If someone has a problem, we investigate that. And then we provide technical expertise. We can review insurance policies, but the item here that we do is we're here to assist with the NSA questions and complaints. And one of the ways that we think that we can help you as providers is to assist with that, facilitating the communication or addressing any problems or concerns that come up regarding the NSA. So I think one of the most important things that we're going to let you know is that this is where some of your resources are. Go to our website. We have basic information about the NSA. As more guidance is developed, we'll be adding information. We also have links to CMS that will take you to additional information that you may need to know as a provider. This is how you can contact us. That's a direct number that goes right to the consumer affairs section. We have a toll-free number if you have an Idaho area code, but we also have a specific email address there. If you have questions or concerns about the NSA, then you can send an email to us. We can assist you. You can also file a complaint. We have a complaint form. If you have a complaint about the NSA, you can file a complaint with us via our website. Anybody have any questions about the department or our role with the NSA? Okay. So now I am going to turn this over to William Kuhn, and he's going to talk about the No Surprises Act.
Hello, my name is William Kuhn. I am a Consumer Affairs Officer here at the Department of Insurance, along with Audra Gerard. We specialize in health insurance, and moving forward, we'll be helping individuals with the No Surprises Act, and that includes both insurers and providers such as yourselves. If we could have the next slide, Amy, please. So we want to keep in mind, we've mentioned it before, we'll mention it again. This is a high-level overview. The NSA guidelines are obviously fairly in-depth, but there's always going to be information available on our website. I know there are some on the phone, so just real quick for those who may not be able to see the slides, it is doi.idaho.gov. And there are pages that are set up for both consumers, insurance providers, and healthcare providers and facilities as well. And that does have links to CMS so that you can get some additional information there. And of course, we're always available via telephone and email if you'd like to reach out to us there as well. And any of that contact information is of course on our website. Next slide, please. So let's talk a little bit about, first of all, who the NSA affects. Consumers, we're talking about both insured and uninsured individuals, and that includes individuals who may choose to self-pay for certain services. It affects insurance companies and health plans. And then, of course, healthcare providers and facilities and our ambulance services. So as a consumer affairs officer specializing in health, we obviously have worked a lot with insured consumers and insurance companies, health plans, but we're looking forward to being able to help individuals who may be uninsured and as providers building relationships with you as well. So we look forward to that. Next slide, please. When we talk about insured individuals, there are some groups that it does not apply to, specifically groups who are involved in federal programs, such as Medicare, Medicaid, Indian Health Services, Veteran Services, or TRICARE. When we're talking about individuals who insure, what applies to, these are going to be individuals who are in either group or individual health plans or federal benefit plans. It also applies to some non-federal governmental plans sponsored by states and local governments, some church plans regulated by the IRS, and student health coverage. And as we mentioned before, uninsured or self-pay individuals. There's additional protections in the law for those folks. Next slide, please. So now we're going to talk about no surprise billing, no balance billing requirements that are in the NSA. And once more, this is a high-level overview. We're just getting into some of the main topics so that as we discuss these things, if you have questions afterwards, we'd be happy to try to answer those. Or if not, we can always get back with you if we're not aware of the answer right now. Next slide. So when we're talking about what balance billing is currently prohibited under the law, the NSA is prohibiting balance billing that is applying to covered benefits. So an individual who's insured, if the benefits are covered under their plan, that's who the NSA is going to be trying to protect. Specifically, this involves emergency services when those services are provided from either out-of-network providers or out-of-network facilities, including standalone emergency facilities. Or if an individual gets non-emergency treatment, they go to an in-network facility and are seen by an out-of-network provider. And lastly, the third major area is air ambulance services when those again are provided by out-of-network providers. So those are the three main areas that the NSA is looking at when we're talking about insured individuals. They have to be a covered benefit, and specifically when we're talking with providers who may be out of network. Our next slide, please. So when there's a situation that like one of the ones we just mentioned, where balance billing is prohibited, it's important to understand that the consumer is really only responsible for his deductibles, co-pays, co-insurance that he would have normally paid had he seen a in-network provider or gone to an in-network facility based on the particular situation. Any additional amounts, as our slide brings out, would have to be worked out between the provider and the insurance company or the health plan. And CMS has stated that providers that bill consumers in violation of the NSA could be subject to civil fines or corrective action. And that would be coming from CMS. That would not be necessarily coming from us. If there's any additional payments, again, that's going to be a negotiation between the provider and the health network. So how do we make sure as providers that we're only billing for what is appropriate? The next slide, we have some best practices from CMS. CMS is encouraging providers to bill the health insurer directly. So the process would be that once the individual has received the services, the health provider or the facility would bill the insurance provider. That insurance provider would look at the claims, determine which ones are covered benefits, and allow the provider to know what the consumer's responsible amount is, whether it's a deductible, a copay, co-insurance. Excuse me just a moment. And then the provider could then bill accordingly. It is also important to understand that CMS is requiring providers, if you're out of network and working in a facility, to determine whether or not that facility is an in-network facility for the individual that you're treating or providing services to. It's the provider's responsibility in that situation. Next slide, please. So as far as the payment resolution process goes, basically what would happen is the individual would receive service. You as a provider would build a health plan. Within 30 days of getting notice from the health plan, either of the initial payment or what that initial payment is going to be, if you disagree with it, you have the opportunity to enter into the negotiation period. And there's a notice that needs to be sent. Again, that information and those forms are on the CMS website. If you and the health plan, if you as a provider and the health plan are unable to reach an agreement as to an appropriate amount for the services that were provided, at the end of that negotiation period, there's a 4-day window where you can then enter into the independent dispute resolution. This is done, facilitated by CMS, done through their website. They send that off to an independent review organization who then makes a decision, and that decision is binding. Next slide, please. So there are some exceptions to this where individuals can be balance billed even if they're being seen by out-of-network providers. However, notice and consent does need to be given. There are timelines that are required, and there are certain requirements of providers as far as ensuring that the individual is able to understand what it is they're signing. And we're going to discuss those in just a minute. But notice and consent, there are some sample forms on the CMS website, and it's CMS form 10780 if you'd like to take a look at that. Just a few of the things that you're going to be providing to the consumer when you provide a notice and consent is a notice of the No Surprises Act protections. You're going to have to clearly state that you're an out-of-network provider, that seeing an out-of-network provider does in general cost more than seeing an in-network provider. You'll be required to provide a list of in-network providers that can provide the same service, a good faith estimate, and a statement about the need for prior authorization that may be required for certain things that will be taking place. And again, that's all from CMS, and that's on those forms that you can take a look at and then use to change them for your own particular use. Next slide, please. So as far as timing on balance billing, if an individual has requested to see you as an out-of-network provider, that request is made 72 hours or more before the date of the appointment, then the notice and consent would have to be given to and received back from the consumer 72 hours in advance. If it's under 72 hours, then it would have to be 3 hours prior to the appointment. So notice and consent is not something that is able to be done when the consumer is checking in for the appointment. It does have to be ahead of time. They do have to have time to review everything and take a look at it and make a decision and go from there. Next slide, please. As far as when we're looking at out-of-network providers, balance billing, specifically in emergency situations, the attending emergency physician or treating provider, they would have to determine that that individual is able to travel using non-emergency care or transportation, excuse me. And they would be able to go to a facility that is a reasonable distance, taking into account that individual's medical condition, right? So if we're here in the Treasure Valley, that might be a little bit easier. Some of our rural areas, depending upon what network the individual has, those distances could be further, so you'd have to take that into consideration, of course. But the main point on the first bullet point there is that they have to be able to travel using non-medical, non-emergency transportation. Secondly, they have to be in a condition to receive notice. So this includes both their health condition and their mental ability to understand what it is they're signing. Next slide, please. And there are some timeframes that go into that as well, and we can get into that at a later presentation if we decide to do that. But also, if there's any state laws or requirements. So some states do have additional laws that go along with the NSA, and if you were practicing in one of those states, you'd have to be aware of that. Let's talk about when balance billing is always going to be prohibited on our next slide. So any item that's furnished as an unforeseen urgent medical need is going to be prohibited from balance billing, even if notice and consent has been given. So for example, in an emergency situation, if an individual came into a facility that was out of network, seen by out of network physicians, they were stabilized, they met those criteria that we talked about on the other slides, excuse me, and then something unexpected happened that resulted in an urgent medical need, that would not be allowed to be balanced billed. So you'd have to be aware of that. Likewise, if an individual had agreed to see a provider who was out of network, and at some time during that treatment, some urgent medical need arose, that would not allowed to be balance billed either. That would be prohibited as well. Next slide, please. There are certain times when balance billing is always prohibited. There is, even if a consent is signed, according to law, it's not allowed. Those are items that are related to emergency service, specifically emergency medicine, anesthesiology, pathology, radiology, neonatology, items provided by assistant surgeon, hospitalists, intensivists, diagnostic services, including radiology and laboratory services, and items and services provided by a non-participating provider if there's no participating provider who can provide such item or service at such facility. So if you are the only individual who can provide a particular service on that last bullet point, you would not be allowed to get a consent, a notice and consent from that consumer, as you are the only one that can provide that service. So they would not allow balance billing in that situation. So let's take a look at just a couple of examples and we'll wrap this section up here. On our next slide, we have the example of Zoe, who's a 26-year-old female. She has marketplace coverage. So she went through, in our state, Your Health Idaho. She's working as a teacher. She has an average knowledge of health medicine. She develops severe pain, swelling and redness in her right calf, becomes concerned it may be dangerous. So she travels to a local hospital emergency department that is in her health plan's network. She has a venous ultrasound. The radiologist, who is out of network, reads the ultrasound, which shows a deep vein thrombosis. Zoe is started on medication and discharged from the emergency department. So here's our question. Do the No Surprises Act balance billing protections related to emergency services apply to the radiologist? And if we go to the next slide, we see the answer is yes, they do. Zoe sought care for a medical condition that, and this rest of this sentence is basically CMS's definition of an emergency medical condition. Using reasonable layperson judgment, she thought was an emergency medical condition that needed immediate medical attention to avoid serious jeopardy, impairment, or dysfunction. Per the No Surprises Act, out-of-network providers are banned from balance billing for emergency services provided for emergency medical conditions. Emergency services, including ancillary services available to the emergency department to evaluate whether an emergency medical condition exists, such as services of a radiologist who reads an imaging study. And if you remember on our previous slide, radiologists were one of the groups that are always prohibited from balance billing as well. So our next example, please. This has to do with Carlos, 62-year-old male, employer-sponsored health coverage. He's involved in a ski accident, sustains multiple injuries. He's taken to the closest hospital, which is out of network. undergoes surgery to repair multiple leg fractures. Once he is stable and out of surgery, he is counseled on the option to transfer care to another local in-network hospital for the duration of his recovery. His treating physician determines the safest form of transport, given his medical state, would be via ambulance. Carlos knows the hospital he is in has an excellent reputation and wishes to stay there for his recovery. The hospital provides a written notice and gets his written consent to waive his balance billing protections under the No Surprises Act. He remains inpatient for 2 additional days and is ultimately discharged home. So here's the question. Does the No Surprise Act prohibition on balance billing for emergency services apply to all days Carlos received from the hospital? So a notice and consent was given to Carlos. He signed it. But as we look through this, is there anything that might lead us to believe that the No Surprises Act would actually apply to all days and that notice consent was not able to be enforced? Let's take a look at our next slide, please. So the answer is yes, the No Surprises Act does apply. The hospital is banned from balance billing Carlos for items and services provided prior to being stabilized. The hospital is also banned from balance billing him for post-stabilization services provided after surgery, despite obtaining written consent from Carlos to waive his balance billing protections under the No Surprises Act, because he could only safely be transferred via ambulance. The hospital can't seek consent from him to waive his balance billing protections under the No Surprises Act specific to post-stabilization services. In the event an individual requires medical transportation travel, including transportation by either ground or air ambulance, the individual is not in a condition to receive notice or provide consent. So again, because Carlos was needing to be transported via an ambulance, even though he signed it, that notice and consent is not enforceable. Our final example that we're going to look at in this section has to do with Rhonda. 50-year-old female with employer-sponsored health insurance discovers a lump in her breast. Primary care provider orders a mammogram, which shows a suspicious mass. She's referred to local in-network hospital's outpatient department for a biopsy. Biopsy is reviewed and found to be negative for malignant cells by a pathologist who happens to be out of network. So how much can the pathologist bill Rhonda under the rules of the No Surprises Act? Our next slide, please. Under the No Surprises Act, the pathologist is banned from billing Rhonda more than the in-network cost-sharing amount as determined by her health plan. The pathologist is an ancillary service provider, is banned from obtaining consent from the individual to waive these balance billing protections. And so that's our last example. We do have some definitions that we'll bring up on the screen. We're not going to read these. We're just going to touch on a few things. I'm sure as providers, you're very familiar with balance billing. Surprise billing, what CMS is referring to is these unexpected bills that an individual may get. In some cases from emergency care, in some cases when unknown to them, a out-of-network provider helps with a procedure at an in-network facility. Let's go to the next slide, please. Just for clarification, I know it's come up in some other webinars that I've listened in on. When we talk about emergency services, if we look at the emergency medical condition, we touched on it in our example of Zoe, but what CMS is looking at is a medical condition, including mental health conditions or substance use disorder, manifesting itself by acute symptoms of sufficient severity, including severe pain, such that a prudent layperson who possesses an average knowledge of health and medicine could reasonably expect the absence of immediate medical attention to result in a condition that places the health of the individual in serious jeopardy, serious impairment to bodily functions, or serious dysfunction of a bodily organ. So when we look at what an emergency medical condition is under the NSA, it may be different from what you as a healthcare provider would necessarily look at, but it does go off of that prudent layperson definition. So our next slide, please. Participating versus non-participating, both facilities and providers. This basically comes down to whether or not you have a contractual relationship, whether directly or indirectly with the health plan, whether that's a group or individual health plan. Next slide, please. And we'll hand it back over to Amy.
Thank you, Will. So again, as we're going through this, some of the language we have in here, it is CMS's definitions, for example, and CMS, as we've said multiple times now, is providing the guidance. I know that initially when we start looking at this probably you as a provider, it might be a little overwhelming. So as we're talking about this, just kind of, I realize that another important thing that you need to know is that as insurance regulators, we deal with taking complicated legislation and trying to figure it out, working together with the resources we have to try to determine, if you as a provider have questions and you're not quite certain what something means, or you want to make sure that you understand compliance, that's what we're here for, is to help try to clarify if you have questions. Also, I've said it again, and we'll talk about our website again. We are providing information on our website. Since the information continues to be updated and developed, as we receive that, we will continue to review it and then try to update our website. For our consumer affairs, we try to keep a lot of the information somewhat basic, but also make sure that we also give you the links to the resources that might be helpful to you. So again, as we're looking, to me at least, and I'm admitting this, some of this when we're looking at the definitions, I'm an insurance person. If there was a lot of technical insurance language, I'm going to enjoy reading it. I'm not a healthcare provider, so a lot of this, to me, it can be new. But again, our role is in implementation is to help you if you have questions, or if you need help in understanding what the requirements are. Why one of our purposes as a resource for you. So the next area, and again, high level, we're talking about some of the patient disclosures. So the patient disclosures, you as a provider need to provide information regarding federal balance billing protections. And also the guidance requires that there needs to be information posted prominently in the location of the facility and on a public website, if applicable. CMS has provided some new guidance regarding this. And we do have from our website, there are links to examples of some of those disclosures. We have Idaho specific disclosures, and recent guidance also is providing information on resources that may be available to you, as far as there are some new requirements regarding posting and having multiple languages available, and CMS does have some resources for meeting those requirements. Again, you can find those model disclosures on our website, and it's doi.idaho.gov. Another area that you need to be aware of is called continuity of care. So continuity of care is when a provider network status changes and you have a patient that's considered a continuing care patient. So the provider is required to accept payment from the plan or issuer for a continuing care patient at the previously agreed to payment amount for up to 90 days after the date the patient was notified of the change in the provider's network status. Also, you need to continue to adhere to all policies, procedures, and quality standards imposed by the plan or issuer for such items or services as if the contract were still in place. And then CMS also provides information on who is a continuing care patient. The individual is undergoing a course of treatment for a serious and complex condition, and there's a definition. I have another slide. CMS provides who that is. The individual is undergoing a course of institutional or inpatient care from the provider facility, is scheduled to undergo non-elective surgery from the provider, including receipt of post-operative care with respect to such surgery, is pregnant and undergoing a course of treatment, was determined to be terminally ill and is receiving treatment for such illness from the provider or facility. And again, CMS provides the definitions of what is serious or complex. Acute illness, a condition that's serious enough to require specialized medical treatment to avoid the reasonable possibility of death or permanent harm. And then we talk about what's chronic, life-threatening, degenerative, potentially disabling, or congenital, require specialized medical treatment cover overall, require specialized medical treatment over a prolonged period of time. And CMS does have an example for continuity of care. And the example is Joan's a 30-year-old female who's insured through her employer. She's 30 weeks pregnant and following up with her obstetrician regularly. At her next visit, Joan is told that her obstetrician no longer maintains a contract with her insurer due to obstetrician voluntarily not renewing her contract. Would continuity of care protections apply to Joan with respect to her obstetrician? And the answer is yes. I'm not going to read through this again. There are examples on our website. Some of these examples are available through the CMS guidance and their training materials, but that just gives you an example of what continuity of care and how that might apply to a patient. Let's talk a little bit about provider directories. Another requirement you need to be aware of is that any healthcare provider or facility that has or has had a contractual relationship with a plan or issuer is required to provide items or service must submit the provider directory information to a plan or issuer at a minimum. And I believe, so this is some guidance at the beginning of the network agreement with a plan or issuer, at the time of termination of a network agreement with a plan or issuer, when there are material changes to the content of the provider directory information, the provider or facility, or upon request by the plan or issuer, and any other time determined appropriate by the provider, facility, or HHS. Main thing you just need to know is that the provider directories need to be kept current. There is some new guidance that recently has come out about options. It can be part of the contractual agreement between providers and health carrier and insurance companies as far as the notification. And the NSA requires any healthcare provider or facility that has or has had a contractual relationship with a plan or issuer to provide items or services to reimburse an enrollee who relied on an incorrect provider directory and paid a provider bill in excess of the in-network cost sharing amount. So again, this just shows how this directory and having current information, the intent is to protect the consumer from having to come up with costs that they hadn't planned on. The next area that this is the one that we mentioned, we're here, we regulate insurance, but a component of the No Surprises Act that we will be assisting with is, excuse me, the requirement to provide a good faith estimate for uninsured or self-paid consumers. So if the consumer is uninsured or indicate that they're going to be self-pay, the provider must provide a good faith estimate of the total cost of services for a scheduled medical procedure. And then if the bill is $400 or more over the good faith estimate, the consumer can request a patient provider dispute resolution through CMS, and they would request that within 120 days of receiving the initial bill. So one of this maybe would be similar to requirements and best practice. So what, as a provider, you need to know is that you need to inquire if an individual who schedules an item or service, whether they have insurance or healthcare health plan coverage, and if they're uninsured or if they indicate that they're going to self-pay, you need to provide a notification in clear and understandable language of the good faith estimate of the expected charges, expected services, and diagnostic codes of scheduled services. More guidance continues to come out regarding this and other areas, as we mentioned, and some of the details of how we go about implementing it and being compliant with this area. But also as a provider, you would want to know that you would also need to include expected charges for the items or services that are reasonably expected to be provided in conjunction with the primary item or service, including items or services that may be provided by other providers or facilities. So for example, if I go into wellness, or if I go for a treatment and there may be tests or whatnot that would be sent off and it's expected, then that also should be included in my good faith estimate. So as we mentioned, this is again the information of where you can find information on our website regarding the NSA. You can submit questions about the NSA. You can file complaint regarding the NSA. And also we have links to CMS's website where you have the independent dispute resolution process. And that is that when there's a disagreement between the insurance plan and a provider regarding the disputed amount for balance billing. And then also there are links for the patient provider dispute resolution process on our website that again, will be facilitated by CMS. I'm going to go to the next slide, and this is just, again, if you reminding you how you can contact us, but I understand that we do have some questions, excuse me, in the chat. Let me see, I don't know whether Shannon or Susie, if someone wanted to facilitate that. Let me pull it up real quick. We'll go through some of these.
It looks like your team is already on top of answering some questions.
Okay, I'm looking at it right now.
Yeah, Amy, I think we've been able to provide some responses, but maybe there's some questions. Somebody wants to ask a live question, maybe.
I'm just reading through it. So yeah, if anyone has questions they'd like to ask. Oh, great. Thank you, Wes. I see that we have some additional assistance here.
Does anybody else on the webinar have a question? Please feel free to unmute yourself or put it in the chat, and we'll just hold for another moment to allow you to do that.
But also, oh, go ahead.
No, go ahead.
I say also, feel free to contact us. If you would rather, like I might not want to ask a question in a large group, but please call us or, send us an email if you have questions or if you have suggestions. That's really, this is the beginning of the conversation, and feel free to reach out to us after the presentation if you have questions.
Okay. Hi, this is Brenda at Minidoka Medical Center. I have a question.
Yes.
One of the other WebExes we were listening to, they were trying to determine whether or not the patient could just decline the good faith estimate if you offered it to them and they said, no, I don't want it. Do you have to provide it to them anyway, or at least develop it and scan it into their chart? Or if they say no, do you just disregard at that point and move on?
I would say based on other types of compliance that you would want to document that you've provided to them. You may explain to them why that it's a requirement that it be provided to them, and if they still refuse it, then I would document that carefully just so that you have it in your records that they refused it. But, what part of it is so that I think one of the things that can be helpful about giving that estimate is that they have received something in writing so that later on, if there's any question or dispute about what is owed, you have already provided them with that information. So sometimes maybe explaining to them why it's required might help, but I would definitely document that you've attempted to give it and definitely keep a copy of what it is that you had to provide to them.
Okay, thank you.
Welcome.
And it looks like there's a couple more questions popping up in the chat. I believe you just answered this question to clarify, should we be giving a GFE, good faith estimate, to any self-pay patient, regardless if they don't ask for one?
Yes, you are required to provide it to them if it's self-pay or uninsured.
Good. Next question. How do you determine a good faith estimate in an ophthalmology office? Patient can come in for a standard exam in the $280 to $375 $100 range, and the doctor determines additional tests are needed, and after findings needs to take the patient to the operating room. That entire visit will be way over the $400 rule.
I'm not sure that I have the quick answer to that. I think probably we'd want to think about it and get back. Shannon, what do you think?
Yeah, I agree, Amy. I think that's a really good question. I think we can say the spirit of the good faith estimate is that trying to consider asking providers to consider, in a normal situation, what would be included. I think there are some provisions around if something else happens, but this is one we could definitely take a look at and get back to you with some more information.
Okay, and IMA can help facilitate that. We have contact information on both ends.
Perfect.
Next question, when giving estimates, do we need to give the diagnostic fee estimates when those diagnostic services are performed out of the facility?
I believe the answer is yes, based on recent guidance by CMS, that if you know it's anticipated, for the recent information from CMS talks about partnering and how if I'm the primary caregiver that I can agree to provide that information on behalf of whoever I know might be involved in the treatment. And we can double check that question, but based on recent guidance, I believe the answer is yes.
And then is DOI willing to share the slides with the participants?
Yes.
Excellent. Also for the participants, after the close of this session, we'll evaluate being able to post the entire presentation on the IMA's YouTube channel as well. So we will follow up with participants and make those resources available to you as they become available. Next question, we have a same-day orthopedic walk-in clinic. The GFE is not required for less than 72 hours, correct?
I am not certain of that answer. Shannon or Wes, do you know?
I'm not either. Let us double check that.
That's a good question for walk-in. Wes?
What I'll, again, do excuse us if we get something wrong. We're all trying to give you the best advice as we understand it. But what I'll say is my understanding is if it's unscheduled for scheduled services, the GFE is not optional. For unscheduled, essentially like a walk-in, I think the person has to request, you could offer it, but the person could request one. It may not be required for unscheduled kind of walk-in situations unless the person requests it. Again, my understanding as of today, we'll definitely follow up if we understand something different.
Great. Sounds like there will be lots of opportunity to learn more and follow up.
Yeah, and the only thing I'll add to a prior comment as well is about some of these, I think it's somewhat implied even by the name, right? A good faith estimate cannot encompass every scenario and every potential outcome. And I don't think they went into too much, but there is in the slides, but just because it wasn't on the good faith estimate doesn't mean that if there is a need for additional services, those won't be able to be charged. I hope I didn't have too many negatives in that sentence. There is a dispute process if costs do come in higher than the good faith estimate. You all may be aware of that. I think you brought it up, Amy, or the other staff, and that's part of it's good faith, the idea of reasonable what is to be expected, but it's not binding. It's just it would be something that would be part of that dispute resolution process of what was included on the good faith estimate, what wasn't.
Okay, thank you for that clarification. Another question, are providers able to utilize the DOI process for disputed payments that fall outside of the NSA?
So is the question if it's not an emergency situation?
Jamie, would you like to clarify the question?
Yes, if it's a non-emergency situation, or if it's something that wouldn't fall inside the scope of the No Surprises Act in terms of out of network and when that process can be elevated to the feds, are there lower level interventions that can take place at DOI in these instances?
I would say what we usually would say is you can give us a call and let us know what the situation is so we can determine how we might assist. Prior to the NSA, there have been times, we don't always get in the middle of discussions regarding payment. Often a consumer is the one that would come to us filing a complaint if they are trying to get a claim paid. But we have in the past facilitated where maybe a provider is trying to work with an insurance company to get payment, and there may be a few times, for example, maybe there's technical issues. What we usually do is we kind of facilitate the conversation to try to help get a resolution. So that's why I'd say right in that screen, the NSA at doi.idaho.gov, you can go ahead and email something to us. You can contact us at the phone number there, the 208-334-4319. We are in Boise. If there's anyone on the line that's Northern Idaho, I realize we are an hour behind, but give us a call and then we can discuss what your situation is and then figure out how we can assist you. But as I think I mentioned earlier, we do have relationships with providers. We regulate, with insurance companies, we regulate them. And often we may be able to help facilitate communication and hopefully a resolution to if you're having a problem.
And I would just add to that, Amy, Amy's pointed out a few times, but there are requirements for carriers, for insurance companies under the No Surprises Act. And certainly the department has been working with carriers to make sure that they are adhering to those requirements and following through with those expectations as well. So yes, just give us a call if you have questions or a situation. We'd love to talk about it.
Thank you. And for everyone's benefit, if somebody should email the NSA at doi.idaho.gov, what's a reasonable time frame of when they might expect a response?
We have a standard response that says, you'll hear from us within 3 days for certain things, but typically you're going to hear from us promptly. The only unique situation we're all in is with the pandemic. Sometimes some things may take us longer, but we will at least reach out to acknowledge that we received your contact. We regularly, the reason why that is a general email address is we have somebody that's checking that daily. And again, we will try to promptly acknowledge that we've received it, and we'll let you know. Sometimes we expect that we'll have questions that we may need to do a little research. We may need to use our connections and contact CMS for clarification, but we will definitely get back to you promptly. And typically it's often the same day or the following business day.
Excellent, thank you. Are there any other questions from DOI? Any other comments you all like to share? Okay, seeing none, I just want to thank you all for your time. For participants, you can see we have a wealth of resources here available to you, and we will be following up with webinar participants with links to slides. And once we get the presentation video uploaded to the YouTube channel, so watch for more. And again, with the caveat that this information is accurate as of this time, as we are in an evolving situation. So, and we'll make sure to give that reminder on our further resources. But just want to thank our friends at the Department of Insurance for all of your great information. Thank you, participants, for your time, and please reach out to either the IMA or the DOI with any further questions, and we will be following up soon. So with that, thank you so much, everyone.
Thank you.
Thank you.
Thank you, Susie, and everyone.